Hello everyone, my name is Vernon Maniago, here to present you my NURU 672 Week 4 clinical case presentation. An overview of the health problem. Coronary artery disease is a condition where the coronary arteries become narrowed or blocked. It leads to reduced blood flow to the heart muscle. It affects approximately 18.2 million adults ages 20 and older. Risk factors include uncontrolled hypertension, high cholesterol, smoking, diabetes, obesity, and a sedentary lifestyle. Socioeconomic factors and access to healthcare can also play significant roles. If left untreated, CAD can lead to other serious problems such as heart attack, stroke, or death. Black Americans were 30% more likely to have a mortality from heart disease than non-Hispanic whites. Coronary artery disease accounts for approximately 610,000 deaths estimated annually, which is about 1 in 4 deaths. When you look at here from the American Heart Association, heart disease shows 49% as a leading cause of death for all U.S. adults. Here's my case presentation of a 48-year-old black American male who presents in the ED with chest pains upon exertion for the past 3 days. He smokes 34 cigarettes a day for the past 2 years. Prior to that, he did smoke 1 to 2 packs a day for the past 20 years. Drinks 2 to 3 beers on the weekends. Current blood pressure is 156/92 with a heart rate of 90, and he currently works as a barber. The patient has no current diagnosed medical or mental health history. He reports a dry cough at night for the past 3 weeks. There is notable pitting, pedal swelling, grade 1 times 2 weeks. Relevant social history is a long-term smoker and occasionally uses alcohol. Associated pathophysiology, primary hypertension, genetic and environmental factors includes high salt intake, obesity, lack of physical activity. Elevated blood pressure increases myocardial oxygen demand. There is also arterial stiffening, which is reduced elasticity of arteries due to aging and prolonged hypertension. Moreover, increased peripheral resistance causes vasoconstriction and volume overload, elevating blood pressure. Edema may also indicate heart failure or other cardiovascular issues. Chest pain may result from atherosclerosis from plaque buildup in coronary arteries, reducing blood flow. Ischemia results from reduced oxygen supply to the heart muscle, especially during exertion. It leads to anaerobic metabolism, producing metabolites that stimulate pain receptors, causing angina, either stable angina, which is predictable pain with exertion relieved by rest, or unstable angina, which is sudden, unpredictable pain that may occur at rest. In addition, smoking contributes to atherosclerosis, further reducing blood flow to the heart. The patient presents with chest pains upon exertion with dry cough. There was no noted adventitious lung sounds, no heart murmurs appreciated. Left lower chest wall pain is non-reproducible. No nausea, vomiting, dizziness, or shortness of breath noted otherwise. He is a long-term smoker of tobacco products with reduction in quantity in the past 2 years to 34 cigarettes a day, and he does drink alcohol on the weekends. Differential diagnoses includes heart failure, pulmonary embolism, gastroesophageal reflux disease, costochondritis, or pneumonia. A primary working diagnosis is hypertension-induced angina and coronary artery disease. Recommended diagnostic testing includes electrocardiogram to assess for ischemic changes or arrhythmias, blood tests including serial troponins, the B-type natriuretic peptide or BNP, the complete blood count CBC, complete metabolic panel CMP, which includes liver enzymes, the lipid panel A1C, which is the percentage of glucose over the past 3 months. We'll want to include a chest x-ray as well to evaluate the heart size and if there's any pulmonary congestion or infiltrates. Echocardiogram to assess heart function, valve issues, and the ejection fraction percentage. Stress tests will also be included to evaluate for exercise-induced ischemia. And coronary angiography if CAD is strongly suspected. Treatment plan includes antihypertensives such as angiotensin-converting enzyme inhibitors, beta blockers, angiotensin receptor blockers, hydrochlorothiazide, or calcium channel blockers. Statins if hyperlipidemia is confirmed or per atherosclerotic cardiovascular disease risk estimator recommendations. Antiplatelet agents such as aspirin and per ASCVD recommendations. Nitrates such as nitroglycerin for acute chest pain. Of course, we want to refer a patient to cardiology for further evaluation. And we want to promote lifestyle modifications, including smoking cessation, reduced alcohol intake, healthy diet, and exercises. Follow-up and long-term management. We'd want to have regular monitoring of blood pressure, follow-up appointments with primary care and cardiology. We'd also like to have repeat diagnostic testing as needed and promote lifestyle and dietary counseling. Patient and family education is important to promote education and lifestyle modifications. Importance of smoking cessation and support options. Having dietary changes such as encouraging low sodium diet and a heart healthy diet. Exercising recommendation to gradually increase in physical activity as tolerated, and medication adherence and understanding of potential side effects. The clinical practice guidelines. One of the recommendations for preventative healthcare is from the United States Preventative Services Task Force, or USPSTF. The USPSTF has made recommendations on many factors related to cardiovascular disease prevention, including screening for high blood pressure, the use of statins, counseling on smoking cessation, and counseling on healthy diet and physical activities, including screening for peripheral artery disease and CVD risk assessment with the ankle brachial index, or ABI, and low-dose aspirin use in certain persons at increased risk for CVD. As you can see here in Table 1, for blood pressure, category A, we want to screen for high blood pressure in adults greater than 18 years. Additionally, obtain measurements outside the clinical setting for diagnostic confirmation before starting treatment. More importantly, addressing the use of tobacco. We want to ask all adults about tobacco use. For those who do use tobacco products, advise them to stop and provide behavioral interventions and the U.S. Food and Drug Administration approved pharmacotherapy for cessation. Moreover, we want to ask all pregnant women about tobacco use. For those who use tobacco products, advise them to stop and provide behavioral interventions for cessation. Clinical practice guidelines from the American Heart Association and the American College of Cardiology. And here they recommend guidelines for the management of hypertension and coronary artery disease, particularly using the ASCVD risk score. And based on the risk score, especially for our patient with a systolic blood pressure over 150 and current smoker, there are suggestions where statins should be incorporated into his medication regimen because according to the American Heart Association, statins remain first-line therapy for lipid lowering in patients with coronary or chronic coronary disease. In addition, they recommend that although e-cigarettes increase the likelihood of successful smoking cessation compared with nicotine replacement therapy, because of the lack of long-term therapy and safety data and risk of sustained use, e-cigarettes are not recommended as first-line therapy for smoking cessation. Thus, AHA, ACC provide guidelines for the management of hypertension and CAD, and it is important to educate our patients on the importance of medication and guidelines adherence for optimal patient outcomes. In addition here, as you can see, blood pressure categories from the American Heart Association and American Stroke Association, the blood pressure category and recommendations to when antihypertensive is recommended to be initiated for patients. Antihypertensive therapy should begin when an adult's systolic blood pressure is at least 140 or higher, or their diastolic blood pressure is at least 90 or higher. The normal range should be, as recommended, less than 120 systolic and less than 80. Elevated blood pressure is between 120 to 129 for his systolic and less than 80 for diastolic. And as mentioned, blood pressure for stage 2 is 140 or higher for systolic and 90 or higher for diastolic. In the case for our patient who has not been taking medication or prescribed any medication, his systolic blood pressure was 150 in the ED, and it is unknown what his blood pressure was prior to coming in, but he also is noted to have symptoms, which include intermittent chest pains. So the plan for the patient would, of course, to be admitted to the hospital and be evaluated with the whole team for his chest pain and his blood pressure, and ultimately be discharged with a plan to include, as mentioned, which is medication, therapy, follow-up, nutrition, and of course dietary follow-ups, and exercising as tolerated. Thank you again for your time, everyone. Here are my references.